Okay, good evening, dear students. I welcome you all to this session of INICET recall for the subject of oral pathology. One second. Yeah. See, in this session, we are going to cover some of the recall questions, and we are going to we'll attempt like how best you could have solved this, and what are the further steps we are going to take, and how are we going to proceed with this. Okay, let me go directly to the first question. So I need a participation. Any options which are missing, if you can let me know, we can just see it. Otherwise we'll see that whatever is possible. See, there was a question here, like a patient presents with a deviation of the chin to the left side, which is painless. What would be a diagnosis based on the following radiograph? I could get only this. This is a coronal CT. This is a coronal CT section. I could get this diagram. There is one more technetium 99 scan also. That is not important. Okay, fine. So here, if you see, I've just highlighted this right side. You can see a swelling, radio opacity from the condyle. So that radio opacity from the condyle suggests that it is basically osteochondroma. The other options are right: condylar fracture, TMJ dislocation, condylar hypertrophy or hyperplasia. So this has been a direct pick or discussion from our notes. So for your confirmation, this was the thing that was discussed in our notes, that how to differentiate between condylar hyperplasia and osteochondroma. Osteochondroma will show globular projection from the median margin of the condylar head. So from the condylar head, you will see a globular projection. So that otherwise condylar hyperplasia will show uniformly enlarged condyle. So based on that point, we can easily, and only coronal CT scan is used. Based on this, and we had also discussed an MCQ, somewhat same related. What was the question is, a 17-year-old male complaint of gradually developing facial asymmetry. There was deviation of the chin to the left side only, and CT scan revealed globular projection from the median margin of the condylar head. Except in the discussion, we didn't show any image. But you have to correlating this, so we can easily identify that, or that this the answer is here is the osteochondroma of the condyle. Okay, so this was, so now what I'm trying to do here is I'm just showing you the question and how we have discussed in our discussion during the class, regular class, and how we have what is there in your notes. Okay, so this was a thing that was this was a question, direct question which was discussed, and that is almost similar. Nothing more can be so much similar, that deviation of the chin to the left side, CT scan showing globular projection from the condylar head, and that too a coronal CT. The correct answer here is osteochondroma of the condyle. Second question was, most common developmental odontogenic cyst is? Most common developmental odontogenic cyst is dentigerous cyst. That is again a very common question, radicular OKC dentigerous, and there was one more option here. So that is the, see, you have to see whenever you see this question, which is the most common developmental odontogenic cyst, the answer would be different. Most common odontogenic cyst will be different. Most common developmental odontogenic cyst will be dentigerous cyst, will be a classical answer. There is a simple single liner MCQ that dentigerous cyst is the most common developmental odontogenic cyst, which we have discussed, that it is almost 20% of all the jaw cysts. This dentigerous cyst is the most common cyst. So if the question comes that most common odontogenic cyst, then the answer would be the radicular cyst. A triad of cleft palate, obstructive sleep apnea, sleep disorder, and mandibular micrognathia is seen in Pierre-Robin syndrome, Treacher-Collins syndrome, Clausen syndrome, and there were one more option. So this is a very classical, again, single liner MCQ, where we can see that the Robin sequence is, it is also known as Pierre-Robin syndrome or Robin sequence, where we will see a classical triad. The classical triad which we have discussed is mandibular micrognathia, glossoptosis, and cleft palate. So glossoptosis is also known as obstructive sleep apnea, OSA. OSA is obstructive sleep apnea. So the triad of cleft palate, obstructive sleep apnea, and micrognathia is seen in Pierre-Robin syndrome or Pierre-Robin sequence. Again, as a single liner MCQ which has been discussed. This was a question like it would be like it's a genetic question based upon the mutation of the Ameloblastoma. BRAF gene and V600 gene mutation is seen in Ameloblastoma. That's the correct answer here. Ameloblastoma actually is associated with a lot of genetic mutations. So three important are there. One is BRAF, one is V600, one more is MAPK, MAPK. Okay, so those are the three questions, three genes which are mutated actually in the Ameloblastoma. So sometimes you can get a question based on gene mutation. So this was an unexpected question. Like particularly gene mutations are more specifically asked in the bone disorders. Most common location for ameloblastic fibroma is premolar area, canine region, incisor region, retromolar trigone area. Again, retromolar trigone area is nothing but posterior mandible. Retromolar trigone area is nothing but the posterior mandible. Okay, this was discussed in our notes that the ameloblastic fibroma typically occurs in the posterior mandible. You can see the fourth point that there will be a swelling in the posterior mandible. See, otherwise the main difference, there is no much difference between the ameloblastoma and ameloblastic fibroma. The main difference only is the age. Ameloblastic fibroma typically occurs in younger age, always typically less than 14 years of age. Whereas ameloblastoma usually occurs in a much more older age group. That's the main difference. Otherwise, ameloblastoma, ameloblastic fibroma, you can't differentiate clinically. Most common odontogenic tumor is, again, this is a single liner MCQ, simple single liner MCQ, that odontome is the most common odontogenic tumor. We know that odontome is the most common, and second most common is nothing but your ameloblastoma. Again, this has been typically directly picked single liner MCQ, that most common type of odontogenic tumor are odontomes, ameloblastoma being the second most common type. Ameloblastoma being the second most common type. There was a question, which of the following is used to differentiate between necrotizing sialometaplasia and squamous cell carcinoma? See, basically we know that necrotizing sialometaplasia typically occurs in males, that too smokers, with a palatal ulcer. So it typically looks like a malignant ulcer only, but we should know that necrotizing sialometaplasia will not show dysplasia. Dysplasia is nothing but atypia. So main difference, how to differentiate between the two, is cellular atypia. Cellular atypia or cellular dysplasia is seen in case of squamous cell carcinoma, whereas which is absent in case of necrotizing sialometaplasia. This has been discussed in our histopathology of the necrotizing sialometaplasia, that this will show pseudoepitheliomatous hyperplasia, which is absent in oral cancer or squamous cell carcinoma. Oral cancer or squamous cell carcinoma will show atypia, which is not seen in case of the necrotizing sialometaplasia. So main difference is you have to see for dysplasia. Dysplasia or atypia both are same. Dysplasia or atypia is seen in squamous cell carcinoma, whereas it is absent in case of the necrotizing sialometaplasia. Moving on to the next question, oral hairy leukoplakia histopathology. Ballooning of cells, hyperkeratosis, parakeratosis, all of the above. So this is again a question which we have discussed in the miscellaneous section, where in the viral infection we know that oral hairy leukoplakia is caused by Epstein-Barr virus. Okay, so this Epstein-Barr virus typically will show this is again an image from our discussion video, that there will be a long vertical corrugations on the lateral border of the tongue, and you can see those balloon clear cells. They are nothing but ballooning cells, and the top layer is nothing but hyperkeratosis or parakeratosis. So you can see all of the following features in case of the oral hairy leukoplakia: ballooning of cells, hyperkeratosis, and parakeratosis. All of the following can be seen in case of oral hairy leukoplakia. Which of the following is seen in parakeratinized layer and stain used? There was an image. Actually, I'll show you that image. They wanted to ask about the epithelium and the microorganism. So typically we have to remember that Candidiasis is the one which is typically seen as a magenta color, and that is stained with a pus stain. The other options we could rule out like TB and ZN stain. How we can rule out this was a discussion from the notes, that candidal hyphae will show this color. This is called as magenta color, and they are typically stained with pus stain. Even in the DVT, there is DAMS visual treat. There is an MCQ where it will be discussed that in acute candidiasis, fungal pseudohyphae are seen penetrating the upper layers of the epithelium at acute angles. That means in acute candidiasis, the hyphae will penetrate the epithelium, and those hyphae are characteristically stained with a special stain, that is pus stain, periodic acid Schiff stain. So the correct answer here is candidiasis, and the stain is a pus stain. Okay. So everything will be discussed, so don't get panic. DAMS, visual treat, DVT session, we will all the images will be discussed, histopath, everything. Not even a single question will come. Like it will be covered everything. This has been discussed in the viral infection section of the fungal infection section for the candidiasis. There was one more question: which of the following will confirm the patient is having benign mucous membrane pemphigoid or cicatricial pemphigoid than other erosive lesions? See, the name itself will suggest, as discussed, cicatricial means scarring. Any blister that occurs in this pemphigoid will heal with scar. That is a basic point. How to differentiate between the benign mucous membrane pemphigoid from other erosive lesions is scarring. The name itself will tell us scarring, cicatricial. So gingival scarring is not present. Okay, that is a basically thing that you have to remember, that which is wrong here. So that is, we will confirm that basically the scarring is a feature that you will be seen in case of the benign mucous membrane pemphigoid. Chances of squamous cell carcinoma is more in. We know that squamous cell carcinoma occurs due to various etiology, tobacco, alcohol, candidiasis, HPV, sharp tooth. But whenever a question has been asked and they have not mentioned specifically in which part of the world, you have to consider it as in India. And we know that in India, aracanate chewing is the most common etiology for all the pre-malignant and malignant lesions of the oral cavity. So alcohol plus aracanate, primarily aracanate, alcohol is a synergistic. So you might ask, why should not we answer alcohol plus tobacco? No, in India, it is aracanate chewing that is more common, and that is why we commonly call the the oral submucous fibrosis as Indian's disease. Why it is called as so common? Because it is so common that recurrent chewing is very frequent the habit, in particular this part of the sub Asian continent. Okay, OPG showing cyst associated with impacted 4-8. There was no OPG. I'll just show you that OPG same. Here we have an OPG for this is the OPG which we have shown in the that it is the 3-8. Same OPG with an impacted 4-8. There was options of dentigerous, OKC, lateral periodontal cyst and other. You have to remember that whenever we get a question like this, we should always think as most common. Even though they have not mentioned, our approach should be most common thing should be the correct answer. Even OKC also sometimes will have like this feature, but the most common would be a dentigerous cyst to the basically has this radiolucency around the impacted tooth. Okay, Pemphigus vulgaris will have what kind of split? Pemphigus vulgaris will basically have a intraepithelial split above the basement membrane. Basically, we know that this is a classical question which we have repeated multiple times in our discussion, that Pemphigus vulgaris, you can see the image there, suprabasilar or intraepithelial split. That is the characteristic split that you see in case of the Pemphigus vulgaris. So obviously there were two options here, above the basement membrane, below the basement membrane. See, intraepithelial means obviously a common sense above the basement membrane. Subepithelial means below the basement membrane. Okay. So the intraepithelial split and above the basement membrane is seen in case of the Pemphigus vulgaris. Maximum increase chance of recurrence of cyst is seen in. We know that basically recurrence of cyst is a most common problem associated with basically the OKC, odontogenic keratocyst. Odontogenic keratocyst is the most common cyst which shows the highest recurrence rate, and that has been classically discussed multiple times. The recurrence rate here is because of the mitotic activity. So the main problem with the OKC is high recurrence rate. History based question was there, a long history based question where a clue was given that it is a round cell tumor. CD99 positivity is seen in. The correct answer here is Ewing's sarcoma. Ewing sarcoma. See, this has been discussed multiple times in our notes also, that this is a direct pick from the notes. Ewing sarcoma is a round cell tumor, CD99 positivity. With CD99 positivity. Even we had framed a question also, which is same, a history based question. A rapidly growing ulcerated tumor of right posterior mandible in a 15-year-old male patient. Histopathology showed sheets of round cells with a glycogen in its cytoplasm. IHC revealed CD99 positivity. The most probable diagnosis is Ewing sarcoma. Okay, so the Ewing sarcoma is the correct answer here. You should remember two things. Round cell tumor, CD99 positivity. Always, classically, the correct answer would be the Ewing sarcoma. There was a question here, identify the histopathology image. So this is again a very bit unexpected question, where fibrous dysplasia, samomatoid, ossifying fibroma, cherubism are the options. See, all these whatever round bodies we can see are the samoma bodies. They are called as samoma bodies. Ossifying fibroma is basically of two types, samomatoid type, trabecular type. What is this round? That is nothing but bone. If the bone is present round like this, we call it as samoma type. If the bone is present like a trabeculae, you call it as trabecular ossifying fibroma. This is a samomatoid ossifying fibroma, which is again discussed in our DVT section. So if this is a DVT slide image, where this is a juvenile ossifying fibroma, sammatoid type. Okay, this is almost a similar image where we can see this. So sammatoid type is considered to be, these are nothing but the types of ossifying fibroma, basically two types. So here we had expected we have got some two or three of image based questions, where one is on the Candidiasis, one is on basically the OPG, one is a sammatoid ossifying fibroma. Okay, so all these are there. Yes. Yeah. So these are some of the questions which had to be we could recall related to the subject of oral pathology. Okay. Any doubts you can post me. You can comment even the group also. So it will be, I'll be able to solve any of your doubts. Okay. And but the DVT session, what will be considering is vast session where all the images are there, that has been classically done by DAMS every year, and that has got a very high winning rate. Many questions you get from that. Okay, direct pick, I can say direct pick will be there from those, and some of the questions which we had discussed, MCQ has been framed, the same type of question has come here also in the paper. Okay, so that's it about this INICET recall session for the subject of oral pathology. Thank you so much.